So Joe's asked me to talk about holding immunosuppression in immunocompromised children. And I was trying to think what I should say on this topic, because it's quite a complicated topic. And it made me think that actually what's most important to get across is that you have to always think about the underlying immunological status of your patient population. And I think that's, to me, that's what's key. That's what I do every day when I think about my patients. I'm constantly assessing what their immunological status is, because that really determines how you're going to manage these patients. And the guidelines that have been talked about this morning are not only important because they give you guidelines as to how best to manage patients, but actually, if you understand the rationale behind them, then that allows you the flexibility when you need it to adapt those guidelines to particular situations. And as our patients become more complicated, as you'll see in my talk, decisions about whether to withhold immunosuppression become very hard. But the more you understand the basis of the immunosuppression and why it occurs and the underlying condition, the better that your management will be. So I think the first thing to say is most children admitted to pediatric intensive care units will be immunosuppressed either when they arrive or pretty soon after they arrive. But not all patients are equally immunosuppressed, and understanding where their immunosuppression, which arm of the immune system is affected, is extremely important if you're going to manage patients most effectively. So the first thing you have to say is, why is it that critically ill children get infections? So the first thing is, this isn't the intensive care unit at Great Ormond Street, even though it may have been some years ago. But the environment is now extremely important. In the United Kingdom, we have a major problem with hospital-acquired infections. And it's actually in our newspapers almost every day. We have a tabloid newspaper called The Sun. It's not held in the highest regard, but they did a whole issue on hospital-acquired infections. And they have a rather simplistic view, but actually not necessarily completely incorrect. The first thing that they point out is that we now have an increasing number of so-called superbugs. In other words, we have bacteria that have co-evolved to become more virulent. And that's not surprising when you think about the use of our antibiotics, the complexity of our patients. And I'm afraid this is something that we're going to have to live with, and we're going to have to try and combat. So we now have more virulent organisms around within our hospitals. So the big one that everyone always talks about in the UK is MRSA. This is a little story that the Sun quite enjoyed, because this was the cleaning boss who they blamed for not cleaning the hospital, who ended up losing a leg because of MRSA. But we now have a problem that our young babies are getting MRSA. This was a recent case of a 2-day-old baby who died because of an MRSA infection, which they must have acquired after birth. So the environment is extremely important. I'll come back to that later, but it is something that we can do something about, and we always have to think about, particularly in the context of immunosuppressed patients. And one of the difficulties that we have is that most hospitals are not designed to allow us to clean them. If you think about the appearance of your wards, of your intensive care unit, and you think about the equipment in there, I think most people would agree that ventilators, computer monitors, computer screens, computer keyboards, pumps, the ventilation system have not really been designed with antimicrobial properties in mind. It's something that's just beginning to emerge in people's thinking, but most units have really are not working in environments that make it easy to protect us from the more virulent strains that are now emerging. So it's something, again, to bear in mind the whole time, is thinking about the environment that you're operating in and how that may impact adversely on your patient population. But of course, most importantly for us is the host. The host always plays a role in susceptibility to infection. And we know that because we have a number of patients with rare conditions where they have specific defects in their immune system. And we know that you can look at those patients and you can make some predictions about the sort of infections that they're going to get. So we know if you're missing antibody, very often because of a molecular defect that means that you can't produce B cells, those patients are particularly susceptible to encapsulated bacteria. But interestingly, they get other organisms such as Giardia, which makes us understand the components of the immune system that help protect against particular pathogens. We're all aware of the importance of cellular immunity. Patients with HIV or severe combined immunodeficiency get a whole host of infections such as CMV, pneumocystis. You can see this is an old slide because it's still classified here as a protozoan, and fungi. And of course, patients who are neutropenic, actually the largest population of seriously immunodeficient patients in our hospitals, are particularly susceptible to fungi and to bacteria. And these are just examples of some of the infections that we've seen in recent years, of gas gangrene, orbital cellulitis, and a nasty Pseudomonas fasciitis. We also know that, I'm sorry, this is a Macintosh to a PC problem here. We also know that some of the conditions in otherwise apparently immunocompetent patients may also have underlying defects that are slightly common but less severe unless you come across particular organisms. So this is a meningococcal disease, and we know that if you're missing terminal complement components, defects in your alternative pathway and in mannose binding lectin, which I'll come to in a minute, you are more susceptible to infection. And the reason I'm just going to tell you a little bit about mannose binding lectin is that some people don't know very much about it, but it is our commonest immunodeficiency, and it does appear to be operating in particular in patients and probably most, particularly children, admitted to intensive care units. So this is a disorder that was actually first described back in the 1980s, where it was found that a low level of a protein called mannose binding lectin, or protein as it was called initially, was the cause for what was described as a common defect of opsonization. I'm sorry about this. It worked on the... So what I would have shown you here is that we detected this in patients because they had a yeast opsonization assay, and they found that what happened is in normal children who didn't have the defect, they could opsonize yeast, and in patients who actually didn't have mannose binding lectin, their neutrophils couldn't opsonize the yeast. So this is a protein that's encoded on chromosome 10, and the gene has a codes for polypeptide that is joined together in these structural subunits, which when joined together as tetramers or higher order oligomers. And the unique feature of this molecule is that it has these carbohydrate recognition domains which combine to repeating arrays of sugars that you find on most microorganisms. And when it binds, it has these serum proteases. The most important one is called MAFS2, which can then activate the complement pathway in the absence of immunoglobulin. So it can bind to organisms, activate the complement pathway, and then that can either lead to destruction of the organism or uptake by phagocytes. Now, importantly, a third of the population have a structural gene mutation in the mannose binding lectin gene. So, as shown in this next slide, in this slide here, if you have a look at the relationship between genotype and MBL levels, you can see that all these patients here have deficient levels. These ones here are profoundly deficient, these have moderate levels, and these have normal levels. So, as I said, it's the commonest immunodeficiency that humans suffer from. Most of the time it doesn't appear to cause a problem, but in certain settings it does appear to predispose you to infection, and intensive care appears to be one of those. And indeed, it's probably the reason why some children get more infections than others. Some of you who have children will know that your children suffered more infections than others at nursery, and they may well have had low levels of mannose-binding lectin. Now, the reason why it becomes very important in critical care is that certain groups have low levels. So these are neonates, and all neonates born in the first week of life have reduced mannose-binding lectin levels. By the second week of life, these have come up to reasonable levels, but it means that all neonates will have relatively low levels in their first week of life. And of course, we know that premature babies who are particularly at risk of infection have most of their infections occurring in their first week of life. And indeed, if we have a look at the rate of infection in our neonatal population, then you find that if you're completely deficient in mannose-binding lectin, so you have none of it, all of the sepsis that occurred in very low birth weight babies occurred in that population, and intermediately amount more in the heterozygous population. And you still have a high level of sepsis in patients who have the normal gene, because actually you have a high rate of infection anyway, but not as much as if you've got an MBL mutation. And I think you can see here in this slide, if you look at the levels of MBL below 1,000 nanograms per mil, and you look at the days of antibiotic therapy, you can see that these neonates end up being treated with more antibiotics. So the concept really is that you have a number of components to protect you from infection, and particularly when you're at risk, such as being in critical care, or you're born premature, or you have another underlying defect, then a deficiency of one of these proteins, such as mannose-binding lectin, could turn out to be extremely important, and is a reason why at least a proportion of your patients will be immunodeficient when they're in the intensive care unit. Now, patients, we know that from work done with a knockout mouse, that the MBL-deficient knockout mouse is particularly susceptible to Staphylococcus aureus. So it may well be that in patients who are susceptible to Staph aureus, MBL is playing a particularly important role. We also know that if we have a look at patients in our intensive care units, that the patients who have localized infection are much more likely to have the wild-type gene with normal levels of mannose-binding lectin, compared with those that get sepsis or get septic shock. And interestingly, it's not just the infection group that are affected by this. Nosocomial infection in patients who are admitted with other causes such as trauma are also more likely to develop SIRS or sepsis if they're MBL deficient. And I think you can see that here in this slide. The white dots are the non-SIRS, and the red dots are SIRS. And I think you can see in the low MBL levels, which are genotypically determined, most of those patients are MBL deficient. But MBL is also important because it may make a difference to how bad you are before you get into intensive care units. So this is work showing that if you're deficient in MBL and you have cystic fibrosis, you're more likely to die. And in work that we've done with Jane Davis at the Brompton Hospital, we've been able to show that patients who are homozygous for an MBL mutation are much more likely to have severe lung disease. And this has obviously got implications when you come to do lung transplants in these patients. So that's one reason why your patients are immunodeficient. The second reason is that most patients arriving in intensive care units already are or develop immunoparalysis. And Mark Peters talked yesterday a bit about this, but for those of you who weren't at his talk, I'll just briefly remind you what this concept is all about. So this is work done back in the 1980s from Varga, showing that patients who died of meningococcal disease had very high levels of tumor necrosis factor. And this really led to the whole concept of pro-inflammatory cytokines being a major mediator of severity and death in patients with sepsis. But we now know from a number of studies, many of which Joe has done and other people around the world, that if you have any insult, such as trauma, surgery, you will induce a pro-inflammatory response, but following that pro-inflammatory response, you will get an anti-inflammatory response. And that anti-inflammatory response is quite profound. So this is work done by Meredith Allen. Some of you may have seen her talk yesterday. And this is just blood taken from patients who have just come off bypass and gone back into the cardiac intensive care unit. And if you take these patients' blood and you add endotoxin to the blood and you see how much cytokines they can produce, such as tumor necrosis factor, you can see it's markedly reduced. So these patients, these individuals have got a problem with producing the necessary inflammatory mediators when they get a stimulus. Now, we can get some idea of how immunoparesed you are by measuring MHC class II expression on the surface of the monocyte. It's a slightly easier way of doing this than measuring TNF production in vitro. And I think you can see here that this is following bypass that many patients between days 1 and 3 have some level of immunoparesis. And I think you can see that here. This is the MHC class II expressed on the monocytes. This is pre-op. This is at day 3. And you can see during day 1 and day 2, most of the cells are not expressing very much MHC class II. And Meredith went on to show that, in fact, if you have below a certain level of this, in this case 60% of your cells expressing class II, you are more likely to suffer from sepsis or SIRS. We've gone on to have a look in a number of other situations. This is a study we did comparing laparotomy with laparoscopy in children undergoing Nissen's fundoplication. And what you can see here is that in both groups of patients you get a marked reduction in MHC class II expression, but it was more profound in patients who had the laparotomy, suggesting that actually the operative stress may be an important marker, important cause of how immunoparesed you may become. And indeed, you can have a look at other anti-inflammatory molecules such as IL-1RA, and you can see the same pattern, which is that post-operatively these anti-inflammatory molecules go up and they add to your immunoparesis. This was showing a more detailed study showing the effect of operative stress. And if the operative stress was high, here you had a more profound immunosuppression in these patients. So all of your patients coming in from surgery or from trauma will have some degree of immunosuppression. And indeed, Mark Peters, who spoke a lot yesterday, did a study looking at MHC class II expression in our pediatric intensive care unit and found that nearly all of the patients arriving in the hospital that had a single or multiple organ failure had evidence of immunoparesis or paralysis. We've now gone on to be able to look at this by looking at gene expression. I talked a bit about this yesterday, but all this blue here are genes that have been switched off, and these are patients that have arrived in the intensive care unit. This is work from Hector Wong's recent study published in Blood. And so we know that by the time you come into the intensive care unit, you've already switched off a lot of your pro-inflammatory genes. Now, a really intriguing and important paper from Joe a few years back also shows that that's not the only reason why you're immunoparesed in intensive care. You have a number of other mechanisms that lead to cell death and lymphopenia. And in fact, this just shows the potential cause of lymphocyte depletion through apoptosis. And you can see that the levels of lymphocytes in patients with multiple organ failure were really either below 1,000 or just touching around that area, much lower than patients who did not have multiple organ failure. And Joe went on to show that in these patients, if they died, you frequently found organisms at post-mortem which indicated that they did have an underlying infection. It just hadn't been adequately controlled. So most children admitted to PICU are immunosuppressed, even if on the face of things they were otherwise normal before they got admitted. But a proportion of patients, and as we heard in many intensive care units, this number now is above 50%, are profoundly immunodeficient. They either are born with an immunodeficiency or they've had therapies which have made them immunodeficient. And you really have to understand this population if you're going to treat these patients effectively. So if you have a look at the reasons why you get admitted to intensive care units, infection is a very important one. But we now know that a lot of those patients don't have a normal immune system before they arrive in the unit. that many have malignancy, a primary immunodeficiency. In our unit, we're now doing gene therapy, so we have patients with gene therapy, HIV, vasculitis, lupus. Transplants is an increasing population that we see in our units, bone marrow, heart, lung, kidney. And of course, patients who have anatomical defects are also at risk particularly at risk of infection. So here we have a neutropenic patient who's had a necrotizing fasciitis, and you can see just how severe it is. And this is the sort of problem that we occasionally see in our intensive care units, and it's extremely difficult to deal with. And really, you want to try and prevent these from ever occurring in the first place. So if we just go back to the original observation, which is now back in the 1960s from Bodie, that there was a relationship between circulating leukocytes and infection in patients with leukemia. And it amazes me, and I'm sure it does with Joe, that people hadn't really crossed their minds before the 1960s. That might be why it was that you got infection following chemotherapy. But it's an amazing paper, and I would advise anyone who really wants to see how someone working in the early years and just using their brain to analyse what was going on, to read this paper, because I still find it remarkable. So Bodie started from the premise that infection is the major problem, and really started to have a look at why that was. And what he did was he took 52 patients with ALL and AML, and they had a rather simple treatment regime, and by the end of the treatment, only 5 patients were alive. 14 patients never achieved remission, and they also observed in the study that you were much worse off if you had AML than ALL. But most importantly, what they found was that once your neutrophil count dropped below a certain level, you were very likely to get infection. And the neutrophil count affected not just the number of infections, but also the length of infections. And so it was bad news if you were lymphopenic. But particularly pertinent to what Joe's found is that actually the spectrum of pathogens is different from patients with congenital neutropenia. And that's because it's not just your neutrophils that get affected by chemotherapy and drugs, it's also your lymphocytes. So these patients were also deficient in lymphocytes, and that's why the spectrum of organisms that patients treated with chemotherapy is greater than patients who have congenital neutropenia, because there's more widespread immunosuppression. And as I said at the beginning, understanding the nature of your immunodeficiency is very important if you're going to give optimal therapy to these patients. And of course, they observed that if you didn't get the neutrophils up within the first week of infection, you died. Now, it's not quite that bad now, but it does make the point that the longer your immunosuppression lasts for, the worse your outcome is likely to be. So it's something we really have to do, we have to deal with. So one of the major groups of patients that we now deal with in our intensive care units are the patients who have a primary immunodeficiency, and in those patients when they've had their bone marrow transplant, and then in the heart, lung, and renal transplants, and in patients with HIV who get infections such as pneumocystis. And this population are at risk of infection for 2 reasons. The first is that they have deranged immune systems. So they are liable to get a whole host of infections, both viral and bacterial infections. But there is another problem in this transplant population. And it was really highlighted in this article that, again, Joe was involved in, where he had a look at the immunosuppressive medications that patients are on and how this may affect your susceptibility to infection. And he made the point that, of course, we know about your underlying your relationship between your underlying immunodeficiency and your susceptibility to a whole host of microorganisms. And indeed, as I pointed out at the beginning, these we know about the susceptibility pattern from patients with rare congenital defects in their immune system. But of course, many of these patients are also on immunosuppressive therapy, because without the immunosuppressive therapy, then their bone marrow transplant or their organ transplant won't actually survive. So in a sense, in many of these patients have a double immunodeficiency. And this is just a list of some of the drugs that are now used in patients, these immunosuppressive agents, and they all cause profound immunodeficiencies for one or more of your immunological arms. You really have to know how these are operating if you're going to know how to manage the control of these drugs in your patient populations, and I'll explain why in a minute. One of the problems that we now have is that we've worked out that various ways of making sure that the patients don't die when we first give them their transplant. And one of the ways of doing that is reducing the intensity of the treatment for the conditioning regimes that patients have before their transplant. But there has been a problem with that, and that is that you have to use more immunosuppression to prevent graft versus host disease or rejection of the transplanted organ. And so we're seeing more EBV-related lymphoproliferation, and we're also seeing more infections such as adenovirus infections, of which really the only effective treatment is to make changes to your immunosuppressive regimes and actually reducing them. This is an extremely difficult task, weighing up the pros and cons of when you can and cannot reduce your immunosuppression, and it's something that we're going to have to become experts at in the years to come. So what can we do to help ourselves manage these difficult situations? So the first thing we can do is make sure that we optimize the existing immunity we've got. If you've got a particular defect in your neutrophils, for example, what you don't want to do is to puncture the skin more than you need to. You want to make sure that mouth care is good, because this is a site of infection that's not affected directly by your neutrophils, in the sense that you have epithelium there, and the epithelial can provide some protection and resistance to infection. And it's the same with your gut. Looking after your gut is extremely important if you've got an underlying immunodeficiency that doesn't directly affect the gut. So look after your immune system, the immune system you've got. Then think about what you can do about reducing your immunosuppression. This is just recent study showing that they took cells from patients with rheumatoid arthritis and cultured them, and then had a look at what various immunosuppressive drugs did to those cells. And you can see here, these are controls here. But these three drugs, one was steroids, one was methotrexate, and one was diclofenac, caused quite marked disruption of these cells. So these cells can be very harmful to your tissues, and you have to think very hard about whether you really need them. You need to make sure your nutrition is good, particularly in malnourished neonates. Work that we did some while back showed that if you are on TPN, solely on TPN for long enough, then your neutrophil function markedly deteriorates and your susceptibility to coagulase-negative staphylococci increases. But you've really got to understand the complexity of your patient's condition. And I think this is the problem that many of us are facing now, which means that we can't give a blanket stop immunosuppression the minute you see a patient being admitted to intensive care units. You have to understand when you need the immunosuppression, which immunosuppression you need, and how to use it. And I think this study done in animals really highlights this point. This was a study done by Hayward, where he looked at what happens when you combine various immunodeficiencies in knockout mouse and gave them cryptosporidium. And what he found was, depending on your immunodeficiency, the nature of your your infectious problem changed. So, for example, if you knock out CD154, these patients couldn't clear the infection, and about half of them developed a biliary complication. Whereas if you had interferon gamma knockout mouse, then these patients all died. And when you started to combine them, you had a mixture of the various conditions. So it's dangerous to lump all immunodeficiencies together. You do have to think about the subtleties. Secondly, we now know that some conditions, such as HIV, may be worsened by immune activation. And in some of these patients, steroids can be helpful. So in some settings where you don't have antiretroviral therapy, steroids can actually make a difference and improve survival in the short term. So it's something one always has to bear in mind. And then if we think about conditions where we automatically think that we can use steroids or immunosuppressive agents such as pneumocystis carinii, where we think this is actually important in the management of these conditions, you have to be aware that these can also cause problems. These are 2 case reports of fatal infections caused because of the immunosuppression caused by the pneumocystis. And in this one, this patient got a fatal CMV infection causing adrenal failure because of the concomitant steroid administration. And this just shows you the adrenal gland after it's been affected by the CMV. We also have to think about our patients with lupus and other rheumatological conditions. These patients very often require potent immunosuppression if they're going to survive their intensive care, but they're at risk of getting fungal infections. And we've had a few fatal disseminated fungal infections. It's something you have to be extremely aware. So the balance of immunosuppression but infection is something that in some of our patients we just have to live with and we have to handle. And then finally, you can reduce the risks of infection. And we're doing a lot of work at the moment to try to make sure that we reduce the risks to our patients by appropriate hand cleaning, care of lines. And I think any of you who will hear James Sutill's talk later on this week, you'll see what a dramatic change some of the cleaning regimes has made to our risk of infection. We've also gone for better diagnosis. We use a lot of the 16S ribosomal DNA PCRs for making an accurate diagnosis of our infection, because if you can make an accurate diagnosis, then you can at least regulate your antimicrobial cover, target it, and again, you can also think about your immunosuppression. But always remember that there are some downside effects of antimicrobials. Macrolides, for example, may have an anti-inflammatory action, and we really don't know whether that operates to help you or may be adverse for you if you're in intensive care. You have to recognize immunoparalysis and do what you can to reduce it, reduce the time in intensive care if you can, because that's when you're most at risk of getting infection when you're immunoparesed. Joe's doing trials on various agents that may have some effect on immunoparalysis, and these are things that in the future I think we will use to try to counteract at least some of the effects of the immunoparalysis that we see on intensive care. So just finally, this is a difficult area. We should always try when we can to reduce our immunosuppression. It's not always possible in all of our patients, but providing you're all the time thinking about the underlying immune defect, what the risks are to those patients, you can manage the balance between giving your immunosuppression that may be targeted, but also making sure you're covered for the potential pathogens that you may be susceptible to. And finally, we now know quite a lot about what these agents do. They don't just immunosuppress. Methotrexate, for example, switches on quite a lot of genes that may be potentially beneficial. So it's not all bad news for immunosuppression, but you've really got to understand how to use it, what the drugs do, and you've got to think. So my final slide is saying that to handle these difficult situations, the more knowledge you've got about your patient's underlying condition, the better it is. You've got to think the whole time about what's going on in your patients, what their susceptibilities are. Don't just go for blanket guidelines without thinking what's behind them, because you may have to adjust them in any particular patient's condition. And then the final point, and I always feel is extremely important, is the patient changes continuously. Continuous assessment of your patients is vital. They may change from hour to hour. New information may become available on what organisms, for example, they colonize with, which may influence your choice of antimicrobials. And so with those three points in mind, I'll finish the talk. Thank you very much.